Welcome to Section 10 of the Renal Physiology Review. In Section 10, we'll provide an overview of water and sodium balance and define the concept of effective circulating volume. Welcome to Section 10 of the Renal Physiology Review. In Section 10, we will go through water and sodium balance, including body fluid compartments and IV fluids, the regulation of water balance and plasma osmolality, regulation of volume, and disorders of osmolality. We will provide a brief introduction of each before delving into more detail. The regulation of water reabsorption is governed by two mostly cooperative but at times conflicting parameters: body tonicity, which is essentially made up of serum osmolality and estimated by serum sodium concentration. The second is the concept of effective circulating volume. Effective circulating volume usually refers to plasma volume and extracellular fluid volume. However, in extreme derangements of physiology, settings such as sepsis, congestive heart failure, decompensated liver disease, effective circulating volume and plasma volume can differ. Effective circulating volume is essentially the portion of the intravascular volume that is effectively perfusing our organs. Essentially, the blood volume that the kidney and other sensors of blood volume, including the carotid sinus and the brain, see. For most instances, these two mechanisms act in parallel to regulate water and sodium balance. However, at extremes of effective circulating volume, both in the high and low end, these two parameters can be at odds with each other, and one driving water reabsorption while the other would otherwise inhibit it. Plasma osmolality is determined by the plasma ratio of solutes to water. This is a very tightly regulated range, normally between 275 and 290 milliosmoles per kilogram. Because the density of water is 1, and 1 kilogram of water equals 1 liter of water, serum osmolality can be estimated by plasma osmolality, and measured by milliosmoles per liter. The major plasma solutes are sodium and its accompanying anions, but there are also smaller but significant contributions from both glucose and urea. This formula is one that you should remember for your Step 1 exam. Plasma osmolality can be estimated as twice the serum concentration of sodium, plus the concentration of glucose divided by 18, plus the concentration of blood urea nitrogen, or also known as urea, divided by 2.8. Once again, sodium plays a predominant role in the estimation of plasma osmolality. However, when glucose levels become extremely high, or blood urea nitrogen levels become very high, these have a greater contribution on total plasma osmolality. With regard to the regulation of water and sodium balance, there are two important concepts to remember. Body fluid volume, extracellular fluid volume, intravascular fluid volume, etc., are primarily regulated by changes in sodium balance, meaning sodium reabsorption increases total body fluid volume, and sodium losses decrease body fluid volume. Conversely, serum osmolality and its primary determinant sodium concentration are regulated by changes in water balance. This can be counterintuitive, as changes in sodium concentration do not necessarily reflect changes in sodium balance. Changes in sodium balance are reflected by changes in total body fluid volume, mostly represented by changes in intravascular volume and at extremes, changes in blood pressure. Changes in sodium concentration reflect changes in water balance. Changes in serum concentration of sodium reflect whether there is excess water in relation to sodium or decreased water in relation to sodium. When there is excess water, the clinical manifestation is a low serum sodium concentration or hyponatremia. When there is a deficiency of water relative to sodium, the clinical manifestation is hypernatremia or increased sodium concentration. The concentration changes in sodium do not reflect changes in sodium balance. They reflect changes in water balance. Once again, changes in sodium balance reflect changes in volume status. Changes in water balance reflect changes in the sodium concentration and the osmolarity. Most of the times, the changes in sodium balance and the changes in water balance are regulated by independent neurohormonal mechanisms. The changes in sodium balance being the renin-angiotensin-aldosterone system, and changes in water balance governed by changes in vasopressin activity. However, in pathologic states, usually when effective circulating volume, or the volume of plasma sensed by the body's organs, is at either extreme, very high, or very low, there is a crossover between these two systems. Once again, the regulation of water and sodium balance. Effective circulating volume is usually governed by sodium balance. As we said, this is primarily governed by changes in the activity of the renin-angiotensin-aldosterone system. Increased renin-angiotensin-aldosterone system activity increases sodium reabsorption and increases effective circulating volume. Decreases in the renin-angiotensin-aldosterone system have the opposite effect. Body osmolality or tonicity reflects changes in water balance. Thirst, leading to increased water ingestion, and ADH, leading to increased water reabsorption, affect changes in water balance. When thirst and ADH activities are low, water balance goes in the negative direction. When thirst and ADH activities are high, water balance goes in the positive direction. There's increased water retention, and body osmolality or tonicity will go down. As I said, in most instances, these two processes are independent and regulated by different systems. However, when there is a greater than 10% fall in the effective circulating volume, this also stimulates ADH and thirst in the same way that increased body tonicity would. When this occurs, however, then sodium and water balance are no longer independent, and we often see derangements in serum sodium concentration. Fall in effective circulating volume stimulates ADH activity. Increased ADH activity will increase water reabsorption. One can understand this in that the body's primary goal is to preserve effective circulating volume at all costs. At less than 10% depletion, this can be governed by simply increased salt reabsorption. However, as that falls to more extremes, all the stops are pulled out, and both sodium reabsorption increases as well as water reabsorption. Let's briefly go over the concept of volume. Volume essentially equals the water plus the sodium content. All types of extracellular fluid volume, or effective circulating volume, plasma volume, interstitial volume, are composed of water and sodium. As we said before, water follows sodium. Changes in sodium balance thus lead to changes in volume balance. If sodium reabsorption increases, water reabsorption will follow. If sodium balance decreases, there's increased water excretion, leading to negative volume balance. However, rather than the total body volume, the total body free water determines the sodium concentration, which then leads to determination of the osmolality or the tonicity. The amount of total body free water also relates to the extracellular fluid volume. As you can imagine, this is a fundamentally extremely important concept to remember for the USMLE Step 1 exam. While the details will not be asked, the concepts of the regulation of water and sodium balance will be asked. Effective circulating volume is primarily governed by changes in the renin-angiotensin-aldosterone system, leading to increase or decrease sodium reabsorption. Body tonicity is primarily governed by the activity of ADH as well as thirst, leading to water ingestion or water reabsorption. However, when there is extremes of derangements in effective circulating volume, when there is a greater than 10% fall in effective circulating volume. This also will stimulate ADH. This will then increase water reabsorption as well as increase water ingestion through the stimulation of thirst. This is independent then of body osmolality. Thus, one can see why at these extremes of derangements in effective circulating volume, this can lead to an increase of total body water relative to salt, manifested by low serum sodium concentration or hyponatremia. We mentioned this in passing, but let's go into more detail into the body fluid compartments. Total body water is 60% of body weight in males and 50% of body weight in females. The extracellular fluid contains a third of the total body water, and the intracellular fluid contains approximately 2/3 of the total body water. Plasma constitutes approximately 1/4 of the extracellular fluid, thus being approximately 1/12 of total body water. The interstitial fluid makes up the other 3/4 of the extracellular fluid, or then 1/4 of total body water. Let's walk through this with a few numbers. As we said, total body water is approximately 60% of body weight in males. For a 70-kilogram male, this essentially equals 42 liters of total body water. This will be distributed through the intracellular and extracellular fluid. 2/3 in the intracellular fluid, meaning 28 liters, and 1/3 in the extracellular fluid. The extracellular fluid then distributes into the interstitium and the plasma, and 3/4 in the interstitium and 1/4 in the plasma. Thus, one can see, in final, approximately only 3.5 liters of total body water of 42 liters is in the plasma space. Another important concept to remember is that the extracellular fluid and intracellular fluid are in an osmotic equilibrium. Sodium constitutes the primary active osmole in the extracellular fluid. Conversely, potassium serves as the primary intracellular fluid osmotically active molecule. This difference is once again maintained by the activity of the sodium-potassium ATPase. This is how sodium administration without water will expand primarily the extracellular fluid volume space. Once again, we can equilibrate sodium and volume. When there are changes in extracellular fluid volume, these manifest clinically in different ways. When there is too little, you see on the picture on the left, decreased skin turgor, which is a manifestation of decreased circulating volume. More commonly in clinical medicine, we see problems of too much in terms of extracellular fluid volume, and these are manifested by the picture on the lower left, ascites, in the middle image, pulmonary edema, and the image on the bottom right, peripheral edema. IV fluids are often administered in the clinical setting, so it is important to familiarize yourself with the different IV fluids. The two major types of IV fluids are crystalloids and colloids. Crystalloids are primarily electrolyte solutions. They do not readily cross plasma membranes, but do readily cross capillaries. Crystalloids primarily remain in the extracellular fluid. They distribute evenly within the ECF, diffusing along the capillary walls to equilibrate intravascular and interstitial volume. Because the ECF is made up of the intravascular and interstitial space, crystalloids administered will distribute evenly in the same way. Examples of crystalloid solutions are normal saline and lactated ringers. Variations on each of these are used in the clinical setting. Colloids are the other type of IV fluids. Usually these contain large proteins or cells that generally do not cross capillary walls. Theoretically, they remain in the intravascular space for a longer period. The examples are being albumin or blood products, being packed red blood cells or fresh frozen plasma. While in theory this is true, and this theory is often used in clinical medicine to justify the use of colloid administration, there has never been proven clinical trials to suggest that colloids provide better intravascular volume expansion than crystalloids. A few things about clinical terminology of saline solutions. Normal saline is also known as 0.9 sodium chloride. It is an isotonic solution. The 0.9% comes from the fact that 9 grams of sodium chloride are dissolved in 1,000 grams of water. So there are in total 9 grams of sodium chloride in a liter of water. Normal saline is isotonic to blood. The sodium concentration is 154 millimoles per liter, and the chloride concentration is 154 millimoles per liter. So that the total concentration of normal saline is 308 millimoles per liter. Very close to the osmolarity of blood. Half normal saline has half the concentration of sodium chloride. It is also known as 0.45 normal saline. It is hypotonic to blood, as the sodium and chloride concentrations are 1/2 that of 0.9, 77 millimoles per liter each, so the total osmolarity is 154 millimoles per liter. This solution, again, is hypotonic to blood. The most hypotonic solution administered is D5 water, or 5% dextrose in water. It is 50 grams of dextrose dissolved in 1 liter of water. D5 initially is isotonic to serum, but the dextrose is rapidly metabolized, leaving pure water. Essentially is equivalent to the administration of a liter of pure water. Because the administration of pure water would cause extreme osmotic damage, leading to red blood cell lysis and quickly lead to death, pure water is not administered. Water is always mixed with either a D5 solution or some electrolyte. The pure water will distribute evenly within the total body water, both in the intracellular fluid and the extracellular fluid. This is in contrast to saline solutions, which will distribute only in the extracellular fluid. One thing we will talk about in terms of derangements of serum sodium is the concept of free water. Free water is essentially solute-free or sodium-free water. Free water is created when sodium is separated from water. This primarily occurs in the diluting segments of the nephron, which are water impermeable and carry out active sodium reabsorption. This creates free water in that more sodium leaves the tubular fluid in relation to water. Once again, for review, the two diluting segments are the thick ascending limb and the distal convoluted tubule. Because of their features, these two segments allow for the generation of free water. Conceptually, one can think of dilute fluid as a combination of free water and isotonic solution. So, for example, a liter of half normal saline could essentially be considered a half a liter of free water and a half a liter of normal saline. Quarter normal also can be thought of in a similar fashion. 750 ml of free water and 250 ml of normal saline. It's important to conceptualize these when we think about how each of these solutions would be distributed in the total body fluid space. 1 liter of normal saline, in contrast, contains no free water. As we said, it is isoosmotic to plasma. A liter of normal saline will remain entirely in the extracellular fluid space. It will distribute evenly, where a quarter will remain in the intravascular space and 3/4 will enter the interstitial space. You can see, if a liter of normal saline is administered, approximately 250 milliliters will remain in the intravascular space. This is in contrast to a liter of half normal saline. Remember, we said half normal saline is equivalent to 500 cc's of free water and 500 cc's of normal saline. The half a liter of free water will distribute within the total body water, both in the intracellular fluid and the extracellular fluid, so that only a third of that will remain in the extracellular fluid. In total, 167 ml of fluid. The 500 cc's that were administered will distribute evenly within the extracellular fluid space. So in total, 667 cc's will remain within the ECF. This will then equilibrate between the intravascular and interstitial volumes, so that a quarter, or 167 cc's, will remain in the intravascular space. Remember, this is in contrast to if a liter of normal saline is administered, 250 cc's will remain in the intravascular space. One can then see now how, depending on the goal in terms of volume expansion, different compositions of intravenous fluids will be given. If the goal is to increase intravascular volume, it is best to use a IV solution that will remain only in the extracellular fluid volume space. However, if the goal is to both administer free water as well as expand intravascular volume, half normal saline would be a more appropriate solution. However, if the only goal is to administer free water, then D5 water solution is the most appropriate choice. Remember, this is equivalent to 1 liter of pure water. This will completely equilibrate between the ICF and the ECF, so only 1/4 will remain in the intravascular space ultimately. This is how D5 water by itself is not an effective plasma volume expander, at least not nearly as effective as 0.9 normal saline. Just to summarize IV fluids, crystalloids can be in the form of isotonic or hypotonic solutions. Isotonic solutions are primarily used in restoring intravascular volume because they remain entirely within the ECF. Hypotonic solutions contain free water. This will equilibrate with the ICF and the ECF, and they deliver less volume to the intravascular space. Colloids, in contrast, will remain only in the intravascular space. Colloids clinically consist of packed red blood cells, albumin, or fresh frozen plasma. The drawbacks to colloids are that they are more expensive than crystalloid solutions, and increasingly they are found to be higher risk in terms of adverse reactions to patients. However, they can be useful for replacing blood components in very specific situations. In individuals with severe blood loss, replacing packed red blood cells, and patients with cirrhosis who have hypoalbuminemia to increase plasma oncotic pressure, or in the setting of coagulation deficiencies, administering fresh frozen plasma to prevent further bleeding abnormalities. Let's go through another question. The rapid ingestion of 1200 mL of water will cause the plasma volume to increase by how many mLs? A, 720 mL, B, 480 mL, C, 400 mL, D, 100 mL, or E, 50 mL. A, 720 mL, B, 480 mL, C, 400 mL, D, 100 mL, or E, 50 mL. Remember, water will distribute evenly across the whole total body fluid volume, so that the intravascular fluid volume will only increase by 1/12, or in this case, 100 mL, or D. This concludes Section 10 of the Renal Physiology Review. In Section 10, the key points to remember are the concept of effective circulating volume, the distribution of volume within the various body compartments, and we provide an introduction to how water and sodium balance are distinct but can overlap.